bearing with me, and 4 lectures in a row, and it's kind of like a lot to kind of handle. You guys are used to it. I'm the one who's not practice. All right, so facial trauma, okay. So we're not a level 1 trauma center, but we see level 2 trauma. We take that about twice a week or so. We share that with Baptist and Integris and Mercy, and so rotate that around. Basically, it really doesn't change a whole lot what we do in the ER, but basically means that we have specialists on call those days. So really being a trauma center has nothing to do with the emergency room at all. So it really has more to do with what specialists you have at the hospital, surgeries, and those kind of things. Yeah, you can't help what walks in. Okay, so sometimes you have to kind of deal with things. You can transfer them later, but you got to kind of make sure everything's all right. A lot of times these things you can handle yourself. So we're talking about dental avulsion, okay, facial fractures, orbital fractures, mandible injuries. It's a pretty gruesome picture, I think. So, right, that one is right before you mentioned. That's obviously more of a trauma center thing. All right. So dental avulsion. So
first thing you would worry about with that picture of that patient. Airway. Thank you.
Right. So dental avulsion. These are kind of fun. Not for the patient, obviously, but so usually they have a fall or something like that. So knocked out their teeth. So fun story was. So we had just gotten this dental box. This was several years ago, but it was sitting up on top of our cabinet in the doctor's area, and I kind of noticed it. And, the docs that I was working with at the time, they hadn't noticed it, so I was like, oh, well, let's see what's in here. So we're going through it, and we're like, oh, that's interesting, good stuff. We were talking about, dental avulsions and stuff like that. Like, oh, that never happens, and even if it does, it never looks like the full tooth is out like this. We're watching like a video CD that was in there, and that kind of stuff about the stuff. And, that never happens like that. And just like anything, the ER gods, if you talk about something or you talk about a particular patient, they're going to come back, or that type of patient. No kidding. 30 minutes later, EMS phone rings and you're encoding a person with a nose tube. Like, it's just crazy. So you can't make this stuff up. Just like the colchicine thing. I swear, I was talking about giving colchicine to somebody for gout, and one of the docs, and they're like, "Well, you don't think they're going to overdose on it, do you?" And I was like, "Oh, I don't suspect that they would." Like, yeah, overdose on the colchicine, throw that. And no kidding, like an hour later, some of the colchicine overdose came. So you don't talk about things. So you never mention somebody's name. So you get like a bad patient that you don't want to see, you never mention their name. Okay? So, word of the wise if you're on yeah, never use those words. So. All right, so if it avulsed tooth, you want to make sure that it's not fractured in there and that. So, but we want to know how long has it been out, has it been preserved in any way? So a lot of times people will put it in milk, or they'll put it in EMS, people will put it in their mouth, or put it in saline. Okay. Those are
patients now.
yeah, patient, not your own, not the EMS workers. Don't do that. Yeah. If they're tooth, they can have it. So there's stuff called tooth saver that you have in our dental kit. Usually use saline. That's the big deal. Okay. Especially if it's got some nerves attached to it, it's always good to kind of save those. You want to make sure there's no facial fractures in there. It's supposed to hit, face plant onto a curve or something like that. So get a CT. Okay. So basically, you're going to do some kind of block to kind of numb the areas up. Irrigate the hole out. So put an angiocath on some flushes and flush that area out really good. You want to push the tooth back in the correct position. Okay. So my last person that had this, they knocked out their front teeth, and so trying to figure out which tooth went where was a little difficult, because they kind of had a little snaggle tooth going on. And so I actually thought that they went one way, but then when I put them in, I actually went in better the other way, and think it could have maybe improved their stuff by swapping which teeth went where, but that's, you're not there to be a cosmetic recorrect or anything, so you put them in the right areas. And so if they have a picture of themselves, it's kind of helpful to kind of know where they go, how it fits in there. That's always good. And then asking the patient, hey, does this look right? What you put in? So, you gotta push pretty hard to get it up in there. That's why numbing them, giving some pain medicine would be helpful. Okay. You apply something called Copac, or there's different brands. That's kind of named by me. It's basically Bondo. You put a little stuff on there and mix two areas, some resin and some stuff together. Put it on there, spread it around the surrounding teeth, and then you dry it. I usually take the oxygen tube and just kind of dry it on there a little bit. That helps it dry out pretty good. And then you got to make sure they have dental follow-up, okay? And you get them to see somebody. Because if it's stable too, if they need to take this Bondo off and put some braces on there or something like that. If it's not savable, then you need to get that out and put them temporary or something like that. All right, facial fractures, okay. If you suspect a facial fracture, you always probably want to get a CT of their neck as well if there's some kind of major fracture. Other than, just like a punch or something like that, maybe not, but, some type of mechanism that's pretty strong, car wreck or a fall or anything like that, okay? X-rays of the face are worthless, okay? Remember that picture of the person with the screw in their nose? You saw bones overlapping, you can't tell anything from that. Okay, so, CT, it's readily available, why not use it, okay? Panorex X-rays are going to be more helpful, but I don't know anybody that has those. So if you want to do a neuro exam, an eye exam, okay? Some people, eyes will be swollen shut, they won't want you to open their eye. You've really got to open that eye and take a look at that globe a little bit, make sure it's intact. So you want to check their vision at the extremes. So what I mean by that is when you're doing your visual acuity or your exam with the call of the finger, you need to kind of make sure at each extreme. How many fingers do you see out here? How many fingers do you see out here? And if they have double vision on it, may indicate that there's some kind of that may indicate that there's some kind of entrapment of one of the extraocular muscles, okay? So intrusiveness, so they can open their jaw, and they can be able to chew or eat, okay? So Lefort fractures, I'm not going to cover this, you can read this, it's been on like every test, so I might want to look at these a little bit. So the pictures, so basically the three's really bad, you can move their whole face around. So facial fracture management, so most times I want to get them to some place for pretty severe ones where they can see a maxillofacial surgeon. Sometimes at the very least, you need to call and talk to one of these surgeons on the phone and say, hey, this is what I got. Sometimes they may say, yeah, it sounds good. Make sure they have a soft food diet and they got pain control, and I'll see them in the office this week. Great. You got to follow up. Any type of orbit involvement, you're going to contact ophthalmology, okay? Our ophthalmologists are great. They'll come in and see people, answer any questions, so that's really good. Okay. Make sure they're stable, make sure there's no other injuries. If they fall from someplace, there's some neck injuries, back injuries. Do the full trauma kind of survey and make sure that there's no extremity injuries or anything like that you're missing. Because painful, distracting injury leads you to miss something. So as patients sometimes have trouble swallowing and eating, consuming liquids, so maybe giving some fluids might be helpful. There's some CT images here, so you kind of tell where the swelling is here. That's going to give you an idea. So the fracture here, there. His nose is definitely broken there. Okay. So, orbital fractures, so especially an orbital floor fracture, high likelihood of getting an entrapped muscle, okay? Double vision coming into play here. This is considered an ophthalmologic emergency, you can say that. And they need to see an ophthalmologist quickly. Okay. Sometimes they're just going to follow up in the office, but you need to at least make sure you have the follow-up schedule. So orbital fractures, so the soft tissue, of course, can hamper your exam, so you need to be able to get in there. You can use an ultrasound too, and at the end we'll talk about that just a little bit briefly. If you can't get it open for some reason, most times you give somebody some pain medicine or something like that, we usually kind of open it a little bit to do the exam. And sometimes you can see some stuff on CT as well. So you get a punch to the face, causes everything to move around, can cause some. You see here the vitreous stuff is leaking out of the eye, so that's not good. Baseballs to the eyes, those can cause some pretty severe trauma. So, the face shield or eye shield on them, kind of damp eye shield, so if they have it open at all, it's got to keep it moist and put some antibiotics in there. Mandible injuries, so we have fractures, dislocations. So this is one of those ring structures. So you've got a pelvis or a head. So it could be a coup contre coup. So you get a fracture in one place, there's probably going to be a fracture somewhere else. Okay, so carefully look out for the hardest fracture to see, which is the second fracture. The mouth is stuck open due to dislocation. They can have both, they can have fracture and dislocation, which makes things great. I'm going to skip that video. So jaw dislocation. Some people get this recurrently from yawning. Every time they get a seizure history or something like that, they kind of have a seizure, they'll kind of block it up a little bit. A couple videos, probably just watch one, just going to save some time here. I don't know which one's best.
Good morning. Can you explain what happened to your son?
Okay, well, he was coming to me probably about 9:30 this morning, which is Tuesday morning, and said his mouth was stuck. He yawned, took a yarn and couldn't close his mouth. I mean, yarn, and I thought he was kidding me, so got him a piece of paper and written on the paper that his mouth was stuck. It's time to go to the hospital, get checked out.
All right, same thing. Remember how you had your head back up here against the wall? Carol, back for me. Okay.
How much medication has he had?
4 morphine.
4 morphine? And one of that there.
Just lean your head straight back against the line. I'm sorry, Bill.
Right hand side.
Yeah, I'm trying to just, this is right side. It's
This is the wrong way.
Some other special technique like that?
I just rotate.
Can I do it? Is there anything I can do?
All right, now put your head down. Push it back.
So what do you mean by rotate?
I'm going to push down on his right side and actually lift up on his left side. You can't put his teeth together if he's dislocated.
I think you got it.
Was his jaw pushed out a bit like that?
Yeah, no, right.
Better back like that?
Yeah.
Is that better?
All right.
Okay. Does that feel normal?
Just don't open your mouth
So
wide.
what did you do? What did
So I
you do
pushed
different?
down on his right side and lifted up on his left side while I was rotating the body of the mandible posteriorly. So it's pushing down and rotating like this.
Your teeth are coming together the way they normally feel like they do.
And I didn't feel
So
the usual clump, but
he always has a little bit of an underbite.
Does he have this bite? Is that normal for him? Okay, because his mouth is closing, so he should be reduced.
He didn't feel it.
So how did you know this was just on the right side?
So he said all his pain was to the right side of his stomach. He said when he go on, that's where he felt a pop on the right side of his stomach.
Okay.
All right, so mandible fracture, so it's a little pretty obvious here, right? Everybody see this? This little fracture right through here. Maybe another little fracture here, it's a little hard to see because there's some scattering there from some fillings and that kind of stuff, okay? So usually, otherwise, they actually have to get their mouth kind of wired shut a little bit. So they put some braces on and they wired shut. It's not very fun. The hard part is when somebody they'll be able to get this done, but if they don't have insurance or something like that, they won't be able to get all that stuff taken off. And so a lot of times, sometimes they'll come to the ER and be like, okay, they said 6 weeks and I can get this off. Okay. And sometimes they've had it done in another hospital or something like that. Like, I don't know if I'm supposed to take this off. So, or their wire will break and they'll kind of stick to them or something like that. So sometimes you have to kind of call some people who want to figure out if they're supposed to have things removed. They just come off like braces, so you just hold them off.
Is it not a global fee and responsibility for the people that put it in? to
You would
take
think
it out?
so, but yeah,
Wow.
you would think. So, lip lacerations, these are kind of a high legal thing, so you can really kind of mess up somebody's cosmetic appearance with this kind of stuff, so you need to make sure you do these appropriately. So, some people don't care, but other people are very conscious about these things, so you don't want to leave somebody with a big old hair lip or something like that, so making sure that first stitch is through the vermilion border, okay? And some people, it's hard to tell where that vermilion border is, so African Americans can be a little bit harder to tell sometimes. Some people are just, where there's not a clear border as it is. But so what I'll often do is, especially in kids, but even adults, I'll put that first stitch in, and then I'll have them take a picture with their cell phone or use a mirror if they have one, something like that, and have them look, or have mom look or whoever, and say, does this look like it's lining up right? And so, if everybody agrees, well, then we'll continue. If they say, no, it looks a little off. Okay, let's try this again. So, I just want to make sure.
The other thing that I've done in the past is using a derma pen and go outside of where you're going to put the stitch, because you don't want to put a stitch through a pin because you'll dot and make a tattoo. So go outside and mark the line, because when you put lidocaine in, that blanches, and then you really can't see the vermilion border. So
this is a great time to use a block versus doing it local, because you can anesthetize the whole area. I would say have some localized pain, a little bit further than just that wound anyway. And it's a really sensitive area to try and numb up too. And you don't get as much distortion from doing that. So if you can't get it, nobody's in agreement, so maybe it's time to call plastics, or some ENT doctors will do it. Or if you can't get the patient to hold still, a small child or something like that, if you're going to make it worse or not be able to do it, sometimes you have to sedate them and do that. Through lip lacerations, I don't recommend sticking a probe through there like that. Usually you can tell by looking. If you can't, the easiest way to do this is take a little bit of water or peroxide mixture, have it put it in the mouth, kind of push it towards the wound a little bit. If it starts to bubble and come out, just throw it through. If it doesn't, it's probably not. Okay? So you always soak the inside first, okay? So you use something that's going to dissolve, so the gut or the vicryl that will dissolve in there. And then you flip the lip back over. Otherwise, you suture the outside first and you flip back over. It's going to probably give a risk of tearing the sutures on the outside. Okay. And then these patients through always going home on antibiotics. Nasal fractures, so you can get x-rays, not at all easy to see sometimes, and kind of worthless, honestly. CT, maybe overkill, but if they got some major deformity or like a septal hematoma or something like that, then you probably need to get a picture to kind of see what's going on in there a little bit. So most patients have kind of this expectation that we're going to set their nose in the emergency room. There's a lot of complications with that, septal hematoma, bleeding, posterior epistaxis. So probably not a great idea. Usually getting the swelling down first, and then having follow the plastics to get that done correctly through surgical procedure. Probably the better way to do that. Only if they really kind of lost patency to both nostrils, so they can't breathe through their nose at all, then maybe it's probably good to be. Septal hematoma, so usually from a septal fracture, can be on both sides. It can affect the patency, so if you can't breathe through your nose, a lot of people say, well, that's not a big deal, just breathe through your mouth. It's not really a great idea. Some people breathe through their nose primarily as their main way of doing it, make people uncomfortable. So, especially kids, some obligated nose breathers. So urgent ENT referral. They might need an incision and drainage. These things. This is not something we do in the emergency room. So they need probably some IV antibiotics and infection, monitor the airway a little bit. Okay. And these are high likelihood for abscesses and actually lead to meningitis. And that's what they kind of look like. So always want to document that on any type of facial trauma if they don't have one of these or if they do have one of these. So, case study. So we got this 32-year-old female. She was under a strain driver. Head-on collision at the telephone pole. Okay. So, Buer's porous facial stuff. She's bored and colored. We're getting head CTs, C-spine, face is ordered. Okay. Obviously, she's got some trauma going on there. So, what do we see on this CT? Anything jump out at you guys? You guys aren't radiologists. I gotta say it loud. I can hear you. The right eye, okay, because we're at the feet looking up, right? So the right eye does not look anything like the left eye, right? And there's swelling over there, so I think we can pretty much discern, right? Because look at it, that's our right eye, right? So that makes more sense. So we have that. Well, I see any obvious fractures in that view, but it's just one plane there. So yeah. Then we can get an ultrasound, okay? So it's just pretty easy. You just kind of put a small bachelor probe on the eye and go through it. It should look like the left side there and not look like that. That means there's lots of blood and other stuff within the lobe. That's not good. All right. Questions?